Many long-term care homes face devastation in this province right now. One has lost almost half its residents to COVID-19. For the very ill, perhaps too ill for ventilators, end-of-life care becomes crucial. With us for their insights on the role that can play, two palliative care physicians. Dr. Amit Arya, who specializes in long-term care and holds a joint faculty appointment in the Division of Palliative Care at McMaster University in Hamilton and the University of Toronto. He's at home in Streetsville, Mississauga. And there's Dr. Naheed Dosani, founder and lead physician for Palliative Education and Care for the Homeless, also jointly appointed at MAC and U of T, and he's at his home in downtown Toronto. Gentlemen, as I welcome both of you to the program and thank you for sparing some time for us, let me just start by reading this graphic here. In this pandemic, we need to consider not just treatment for those we may be able to save, but also the suffering of those we cannot. Palliative care should not be seen as a luxury, but as a necessary part of the response to humanitarian crises. It will be up to those running the health system, including our governments, to provide the resources to make sure that happens. At this time of global crisis, palliative care can and will help address our collective suffering. Those sound like very important words, and before we sort of dive into them, Dr. Amit, maybe you could tell me what's the difference between palliative care and just sort of normal long-term hospital care that we think of?
So palliative care is an approach to care which focuses on symptoms alongside supporting family members, as well as helping patients, families, and their health workers make crucial, timely decisions for themselves in the context of a serious illness. So this could be a serious illness such as cancer, COPD, kidney failure, or in our current paradigm, COVID-19, of course. It is not equivalent to end-of-life care, and it doesn't necessarily mean that the patient will pass away. It just means that they're very, very ill at the time.
Well, that was going to be, Dr. Naheed, my next question. Is it pretty much automatically the case that the patient's on the verge of death?
No, so palliative care in Latin actually means to cloak, to comfort, and it's an approach to care which emphasizes quality of life for people with serious diseases. It does include end-of-life care as part of the care approach, but it does span the whole spectrum. And we know with good palliative care, we actually emphasize starting right at diagnosis all the way throughout the journey, even to end of life, and then including the bereavement phase. We know that with early palliative care, people feel better and often can live longer as well.
And what does it typically look like?
So in terms of COVID-19 particularly, palliative care has a little bit of a different face than it might have with other conditions. This includes people experiencing shortness of breath, for example, experiencing air hunger. It can also include managing symptoms like pain or delirium. It can also be supporting a loved one who is having to make a difficult decision on behalf of someone who they care for, who's sick, or it also has to do with system preparedness, which is something that Dr. Arya and I are calling on the system to be better prepared to support palliative care during this pandemic.
Dr. Amit, we know that half the people who are dying of COVID-19 are dying in long-term care homes. How about the other half? Where are they dying?
So I think that's in a variety of settings. I mean, for sure that we know, many patients are coming into acute care hospitals at this time, and that requires sort of palliative care to be provided on the front lines. So in the emergency room, on a specific COVID-19 ward, it's very important that all the health workers who look after patients can address suffering and monitor signs of suffering very closely, in addition to supporting family members and help with those essential conversations.
And can you follow up by telling us this may seem like an obvious and somewhat heartless question, so let me just preface it by saying I don't mean it to be, but how does all of that affect how they feel in their remaining days?
So specifically for COVID-19, we know that if we have the right medications and the right support, we can help to ease suffering. So if someone is quite short of breath and gasping for air and has that air hunger, as Dr. Dosani indicated, the medications and the monitoring and treatment we provide can help them to breathe more peacefully and easy. If someone is restless or agitated, they can feel more calm and relaxed. that sometimes can even allow them to have that space and time to communicate with their loved ones. And connecting them with their loved ones is so important at this time. And I can really say that supporting the loved one and supporting that connection is a crucial part of the palliative care approach.
I hear you. So, Naheed, maybe you could follow up with this. Um, I have to assume that in a lot of cases, people who are dying right now because of physical distancing rules are dying alone, away from family, with not necessarily anybody that they really know with them. How does that affect the experience?
It's a really great point that you bring up, Steve, and we are seeing across hospitals and in our communities due to infection control procedures and protocols that caregivers and loved ones are not able to be with the people that they love, especially when they're approaching end of life. I do worry as a palliative care doctor about the grief, trauma, and loss that people are not necessarily processing. I mean, how can you really grieve when you can't physically get close to the people, procedures, and rituals that get you to that place of closure? The other thing is, I think we need to think about the role of the caregiver in our healthcare system. There's this movement called the essential caregiver. And actually, I've personally witnessed how caregivers are an essential part of our healthcare system, providing care in our communities, in hospices, in long-term care, feeding the people they love, because our system is not able to provide 24/7 care. But on the flip side, I've also seen such excellent examples of COVID kindness. One of my colleagues, Dr. Humera Saeed, who works on our team, actually contacted companies across Canada to get donations of smartphones and tablets so that people who are sick and approaching end of life can be in contact with their loved ones. And so there is a positive side to this too, and I think we can learn a lot from this experience.
That's a nice expression, COVID kindness. I hadn't heard that one before. Thanks for sharing that one with us.
No
Dr.
problem.
Ahmed, having said all that, I mean, your specialty, I take it, is long-term care homes. And I must say that I have been, numerous people have reached out to me since this COVID crisis happened, and they have said to me, my biggest fear right now, one of my parents is in a long-term care home. They're not doing well. My fear is they're going to get COVID and die, and I will never be able to have seen them during any of it, and they will die without me. And I wonder if you could just sort of peel back the curtain for us and tell us, how are things being handled on that front in long-term care homes now as compared to before COVID hit?
Well, I mean, it's a big challenge, and most definitely some of the stories that we're seeing in the media, where we see sort of family caregivers looking through a window at their loved one, are quite heart-wrenching. And this is happening once again, across the country at this time. We know that nursing home patients are actually quite sick. Even before COVID-19, these are patients who are not well, often in their last months to years of life, with incurable illnesses such as dementia or a combination of other illnesses. So this was particularly a vulnerable population. I mean, I have seen firsthand in nursing homes how essential the family caregivers have always been. We see them coming in, spending the 90 minutes with their mom or dad, feeding them culture-specific food, helping with the personal care, which can include changing them, bathing them, helping with bed sores, and so on. And I think at some point it's a challenging decision, which I'm sure our public health authorities are very much involved in, where we're trying to sort of prevent people in nursing homes and many other care settings from getting the virus. But as this pandemic stretches into weeks and perhaps into months, I think there will be a cost for patients that are already socially isolated, such as nursing homes, and are very much dependent on their family caregivers. And it's a balancing act for sure.
Well, I do want to ask about the staff, because clearly, well, one does wonder whether they're certainly not accustomed to having to deal with circumstances like these, but in the main, how do you think they're handling this sort of full court press of COVID-19 consequences?
Yeah, in nursing homes, it's very tough. I mean, firstly, I'm glad in a way, ironically, although I mean, obviously, we're very sad about what's going on with COVID-19 in nursing homes. But I'm glad that there's some attention now being brought to the staffing issues that have been persisting for a long time in these facilities. So we know that they're understaffed and under-resourced always. And it's very important that we try to increase the staffing that's available there. We make sure that they have adequate PPE, and very importantly, that they have training on how to put on that PPE. And of course, all the frontline workers, especially the PSWs, deserve a living wage. They deserve benefits. They deserve sick pay and hazard pay. And we all can see now that it should be very obvious how that's very important for them, but also for the very vulnerable patients that they care for.
Let me do another excerpt here that I want to bring to everybody's attention, and it goes like this. We know that when health systems are overstressed, people who are already marginalized, whether it's by poverty, homelessness, language, discrimination, or historical trauma, are less likely to self-advocate and less likely to be heard when they do. One of the principles of palliative care is to counterbalance this unfairness. Okay, Naheed, why don't you pick up the story there? How does it usually counterbalance the unfairness?
Palliative care is an approach to care which emphasizes quality of life, and it's inherent to that is the advocate role. COVID-19 is not the great equalizer. It is disproportionately impacting communities who experience structural stigmatization and vulnerabilities in our communities. Just yesterday, Steiny Brown at the provincial press conference noted that people from low-income neighborhoods are being impacted. We know racialized communities are being impacted. As a palliative care doctor who provides healthcare to people experiencing homelessness, I can tell you that there's no doubt that people who experience homelessness are also being impacted disproportionately by COVID-19 during this time.
Are you able to sort of put your thumb on the scale at all during this COVID crisis in order to help balance things out at all?
Absolutely. I mean, just to paint a picture for people who prefer more visual description, how can you really mount a defense against the pandemic when the burden of poverty is so high? When you sleep in shelters where you sleep less than 2 meters away from someone, when you dine communally, when hygiene is so difficult to achieve. And while there's been a lot of focus around PPE for health workers, I can tell you that frontline shelter workers in our communities across the province are struggling to have adequate access and maintain an appropriate supply. Many shelters and drop-ins have had to drop in and or reduce hours or actually close, which has actually led to more people being on the streets and in need than greater rates than ever before. So we know that COVID-19 has disparities about where you live and what your social economic background is, but we also know that that occurs in death as well. Death is a social justice issue, and we have a lot of data from Health Quality Ontario that shows if you live in a poor neighborhood, you're less likely to get access to palliative care. You're less likely to get a home visit from palliative care providers, and you're more likely to die in hospital if you didn't want to. These issues are now compounding.
Amit, I wonder if you could pick up the story by talking to us about what kinds of medication you use for palliative care and whether you have access to enough of it given the COVID crisis we're in the midst of.
Yeah, so generally some of the symptoms that we are encountering in COVID-19 are include breathlessness, which is the number one symptom, and the air hunger that we've been referring to. And to treat that, we use opioid medications like morphine and hydromorphone. For patients who also have restlessness and agitation from delirium, we have medications that can be referred to as antipsychotics that we use in low doses in order to help them to feel calmer. And similarly, there are sedative medicines that we use as well if perhaps the latter two classes of medications are not helping. I mean, further to that, we've talked about oxygen, of course, which can play an essential role in helping to relieve someone's sensation of breathlessness. Right now, I can share that through sort of the multiple roles that I hold, I mean, many sort of different palliative care physicians across the country, and not just physicians, but palliative care teams, are having ongoing conversations with their pharmacists and their health authorities and their hospitals on a regular basis, really week to week, to monitor which of these medications is available at this moment and which of the medications are not available. It's really quite a free-flowing situation at this time, Steve.
And if they're not available, how are they rationed out to make sure that it's somewhat equitably handled?
Well, it requires a change in usual practice. I mean, for our sort of usual practice, we actually have kits of these medications, which are kind of referred to in different terminology, depending on where we work, called palliative medicine kits or symptom response kits that we actually store in the home for patients that are quite ill and, receiving home palliative care. And that paradigm is shifting because oftentimes, those medications get wasted and we have to throw them out afterwards. So jurisdictions are now moving towards having these medications available in a timely and tailored fashion. So making sure transportation systems are available to support that as well is really important at this time.
And one more follow-up on this. This may be obvious on the face of it, but again, let's just be sure. I presume if somebody is in their dying days, you don't worry too much in the case of oxy or morphine about addiction. Fair to say?
Oh yeah, yeah, absolutely. So addiction is kind of a different phenomenon, and we know that the patients we generally serve under palliative care have a very low chance of developing sort of addiction where they sort of crave this medication and so on. It's really well established that opioids such as morphine and hydromorphone are extremely safe for patients with shortness of breath. And once again, we know that it's something that's very important. And being short of breath in the last days or hours of life is perhaps one of the most terrible ways to pass away. So treating that respiratory distress is so important at this time, and it doesn't interfere with the actual disease process, and that it doesn't shorten life either.
Naheed, let me ask you to do once again another one of these sort of before COVID and after COVID comparisons. How is this pandemic affecting the palliative care of people suffering from diseases other than COVID-19?
It's a fantastic question. We are talking a lot about the consequences of people who experience COVID, but there are unintended consequences in our healthcare system and in our communities that we're not necessarily seeing. For example, in home and community care, the COVID experience has led to a shortage of PPE, which has led to decreases in people getting access to home and community care supports. I was on the phone with one of the people I care for who's at home, and she's alone, and she's dealing with a life-limiting illness, and she said, I literally hang by a thread, and my supports are the PSW comes once a day and the nurse who checks in on me once a week, but because they don't have PPE, they're not as well connected. We're also seeing that people are a bit confused about whether they should be going into hospital or not when they have symptoms or get sicker. This again speaks to the importance of palliative care in our communities, not just to address people and support people who are dealing with COVID, but to perhaps keep people out of a hospital. And this is one of the added benefits of palliative care. It keeps people out of hospital, which obviously reduces the need for capacity in our health systems, but also saves the system money. But finally, I do want to highlight that there has been a great appetite, an optimistic approach from health professionals who work across the spectrum to learn about palliative care, and many kudos to colleagues, who work in organizations like Pallium Canada, who have provided real-time training and opportunities for people to learn about palliative care, whether it's related to COVID or not.
Okay, gents, in our last 5 or 6 minutes or so, let me just try and get a couple of last issues on the table here. Can I find out, Amit, why don't you go first on this one? How's your life how are you practicing differently now under the COVID-19 circumstances? Like, are you under house arrest most of the time, or are you able to go in and treat patients, or what's happening with you right now?
Yeah, thanks, Steve, for that question. I think it's sort of raises some interesting issues, and I would really say that honestly, things are very different for many palliative care professionals, across the country. I mean, firstly, I was used to always going in to see my patients, and meeting with their family members at the bedside, having family meetings was an essential part of what I did. And now some of my work has moved to become virtual, where I'm still assessing the patient, but it's through sort of a confidential version of Zoom, and I'm connecting with the health workers and then sort of calling, their loved ones. Specifically, that's happening in long-term care. And I mean, we do still go in and see our patients in the hospital, but I mean, as we talked about, there have been sort of restrictions on family coming in at that time. And, so we have to call the family rather than meet them in person. On a personal level, since this started and since I've sort of been seeing and treating some COVID-19 patients, my wife and I made a decision for the safety of our family that I would be self-isolating at home. So I have kind of a separate living quarters where I have my own room, and I have a sort of disinfectant, like a disinfection protocol that I follow when I come back from the hospital to ensure that I hopefully don't spread this infection to my loved ones.
How much are you enjoying the current circumstances?
It's different. I mean, we're trying to balance safety and still trying to stay connected to our loved ones. I mean, I could share that obviously when I got home before, I have two young children who are in elementary school, and it was very routine that they would come running up to me and hug me, and I would chase them around, or they would just jump on me. And unfortunately, that can't happen now. But I mean, I'm lucky that they're old enough that they do understand the circumstances that we're all in at this time. And
Naheed,
alongside that, sorry, go ahead.
or no, finish your thought.
Oh, I wanted to say that, I think a lot of us in palliative care also fear, how people who are, maybe quite isolated and don't have the privileges that, Naheed and I would have are also coping with the social isolation at this challenging time.
Sure. Naheed, how about you? Same question.
I echo a lot of the sentiments that Amit has brought up, but for me, my practice has changed because when the pandemic started, there was a call for people to reach out and support in different ways, and now I find myself answering that call. We're still working in palliative care, but working at the regional assessment centers, meeting people on the front lines and supporting people in their assessments around COVID-19. I also have taken on a new role as medical director of the region of Peel's COVID-19 homeless response. So working at a health systems level with colleagues, government advocates, and community activists to help support structurally vulnerable communities through this pandemic as well. So it's required a different kind of energy, but there's no greater time than now to fulfill the responsibility of what we signed up to do as health workers in our communities to respond to a real and dire need.
And are you essentially under house arrest as well?
Very much the same. There's a strict infection protocol that happens that my wife puts me through when I enter the door, understandably as well. Yeah, same thing.
Understood. Okay, there's every possibility that somebody from the Ontario Ministry of Health is watching this. And to that end, I would like to give each of you the opportunity to offer them some advice. What's not happening right now that you wish could be happening that would make the lives of both your colleagues, yourselves, and most importantly, your patients better? Amit, why don't you go first?
Yeah. So personally, I think that we need a lot more resources in many different in many different community settings. We've learned recently that this sort of pandemic and the disease processes are following these two different curves. One is in the community where we are seeing some positive signs that perhaps that curve is starting to flatten, but the other is in sort of locations that are affected by structural vulnerabilities, such as nursing homes, shelters, and other congregate settings. So we really are, we are seeing this, but we need a bigger focus on those congregate settings where we can support sort of patients in long-term care, in shelters, and in prisons. I'm also a member of the long-term care SWAT team at our hospital, the Rapid Action Team, and have worked with them to try and develop some of those responses. But part of it is that we need more staff in those locations. We need more funding to support the best care that we can provide to those patients in these circumstances.
Naheed, last word to you on this.
This conversation has covered the need for palliative care to be considered not a luxury in this pandemic, but as a core element of pandemic planning and response to action. So I think that's the first thing. And the final thing that I would think about is how we're responding to people who are experiencing homelessness in our communities. Many jurisdictions across the province are responding with prevention, moving people into hotels, on-site scaling up of testing, isolation, and recovery. We need to scale up these options, and they need to be synchronized and coordinated at the provincial level. Furthermore, we need to think about beyond the pandemic. Are we really going to send people who are homeless, who are in these temporary accommodations, back to the streets after the pandemic is over? No, this is an opportunity to address one of society's greatest failures and social ailments, chronic homelessness, and housing for all, because housing is a fundamental human right. History will judge our actions.
I want to thank both doctors Naheed Dosani and Amit Arya for joining us on TVO tonight for a really important and thoughtful contribution to the conversations that are going on right now in palliative care and beyond. Gentlemen, thank you both so much for joining us.
Thank you, Steve.
Thank you. Thank you for having us.
The Agenda with Steve Paikin is brought to you by the Chartered Professional Accountants of Ontario. CPA Ontario is a regulator, an educator, a thought leader, and an advocate. We protect the public. We advance our profession. We guide our CPAs. We are CPA Ontario. And by viewers like you. Thank you.